Seizure and epilepsy are well-known consequences of aneurysmal subarachnoid hemorrhage and have been associated with poor functional outcomes. The data on the incidence of new-onset seizures after the treatment of aneurysmal subarachnoid hemorrhage and the effect of clinical grades on that incidence are limited and variable at best. Furthermore, the question that comes to mind is, how does coiling versus clipping affect that incidence? Baxter Allen and Hal Mangat took on that challenge and published the results in the Neurocritical Care Journal last August 2018. You're listening to the Neurocritical Care Society podcast, and I'm your host, Waz Al-Mufti from Westchester Medical Center at New York Medical College. Today, Sarah Stern-Nezer will discuss the results of this paper with Alan Baxter. I hope you enjoy this podcast.
This is Dr. Sarah Stern-Nezer. I'm an assistant clinical professor at the University of California in Irvine, and I'm here today with Dr. Baxter Allen, who's a clinical instructor and fellow of neurocritical care at UCLA Ronald Reagan Medical Center. Dr. Allen, thank you so much for joining us.
Thank you so much for having me.
So today we're going to talk about your paper published in August 2018 in the Journal of Neurocritical Care entitled Association of Seizure Occurrence with Aneurysm Treatment Modality in Aneurysmal Subarachnoid Hemorrhage Patients. So I'll begin by asking why this question was interesting to you and what made you proceed with this research pathway.
Sure. So I'm dual trained in neurophysiology and neurocritical care, and I've been tailoring my research around my interests, which are the application of neurophysiology in neurocritical care, surprisingly. While I was a fellow at Cornell in neurocritical care, I was working a lot with the neuro-ICU attendings on the indications for EEG in the ICU, trying to figure out, when we should and shouldn't hook patients up, and thought that this was an important question to get towards that final answer.
Yeah, I think it's a really important and interesting question because there's so much debate, or maybe not debate, depending on where you are, who you are, about the best treatment modality for aneurysms, and certainly moving towards endovascular therapy when possible. But some of us don't necessarily weigh these long-term sequelae that, we'll get to in a second that you talk about outcome, as well as the short-term sequelae like seizures. We don't necessarily think about that in our treatment algorithm.
Certainly. I think it's very important in deciding what you're going to use to treat an aneurysm, the skill sets available to you in your institution. So, if you have a neurosurgeon who's very experienced at clipping aneurysms and an endovascular guy who has only coiled a few during fellowship, I think, the calculus weighs more towards a surgical approach. But knowing the risks that surgery adds to the patient, I think, is an important thing to know.
So we'll dive a little into the meat of your paper. So just to summarize, it's a retrospective cohort study of all the aneurysmal subarachnoid hemorrhage patients admitted over a 6-year period at Cornell. Your seizures were defined as observed clinical seizures or EEG seizures, and you dichotomized a little the subarachnoid hemorrhage into low grade, defined as Hunt-Hess 1 to 3, and high grade 4 to 5. I really like that you also looked at a number of outcomes, including GCS at ICU discharge, but followed patients up when they came back to clinic and looked at what the modified Rankin scale was. So why don't you tell us a little bit about what you found and whether you were surprised by these results?
So I'll start off by saying that I was not particularly surprised. The main result that we saw was that in low-grade subarachnoid hemorrhage, seizures were more likely to occur in surgical patients, and seizures in all comers, especially low grades, were associated with worse overall outcome.
And this was, just to add, a total of 282 patients, of which 72% were low grade. For those who haven't read the paper, why don't you tell us a little bit about how EEG monitoring was done and who was selected for that, since you already mentioned that it is an interest of yours from a research perspective as well as a clinical perspective.
So the ICU attending standardized selection of patients that were going to go on to EEG if they had a persistent GCS that was less than or equal to 13 or fluctuating mental status going back and forth between above that and below that, that was unexplained. There were also occasional times when patient may not have met that criteria, but there was concern from nursing staff or from one of the physicians on the team that the patient may have had some sort of clinical event and they wanted to better qualify whether or not that was seizure or not.
And you went on to find, as you mentioned, that seizures were more common in high grade compared to low grade, 12.7% versus 3.9%, although it didn't reach statistical significance. But the number of patients who had seizures was 18, or 6.4% of all patients. You yourself do an excellent review in this paper of prior literature on seizures and subarachnoid hemorrhage, and it seems like this is maybe at the lower end of the reported range of seizures. Do you feel that's true, or maybe you can just speak to the variability that's reported?
Certainly. So if you compare the seizure incidence in our paper to, say, the data from the Columbia group, they were looking just at patients who were on EEG. 9% of patients that had seizures in our cohort were of the total population, not just those that were hooked up to EEG. That includes the clinical seizures, but not all of them were hooked up to EEG.
You comment in the paper on the use of seizure prophylaxis with levetiracetam or Phenytoin. What effect, if any, do you think that the use of seizure prophylaxis may have had on your results?
I think utility of Phenytoin or really levetiracetam at this point is, while it's not necessarily well supported by data, it appears to be the standard of care in most places where I have been, or at least talked to. At UCLA, where I'm training now, patients will be on AEDs while they have the drain in place. At Cornell, AEDs were frequently stopped after the aneurysm was secured, unless there was a clinical or electrographic suspicion or confirmation of seizures. I think it may have decreased the incidence of seizures overall, but I don't think it would change the number compared to the general population.
Absolutely, and that makes a lot of sense. And one of the strengths of your study is that it seems the consistent care that you get at one high-volume center makes it a little easier to make those comparisons across patients. I want to talk a little bit more about the results you had. Tell me a little bit about what you found in terms of seizures and how it related to secondary insults, as well as to outcome at discharge from ICU and at follow-up.
So, as you are well aware, seizures are both a symptom of injury and can be a cause of injury. We know from metabolic data from, again, Clausen's group, from Vesta's group, from Foreman's group, that when you have seizure activity, you will have metabolic stress, which can lead to damage. Because of that, seizures would be associated with worse outcome. You're going to have more damage to the brain in patients who've had seizures than those who are not.
And you did find that the mean GCS on discharge from ICU was significantly lower in the patients in your whole cohort who had seizures, and the MRS was similarly lower at an average of 4.1 months after discharge. So a lot of the sub-analyses, including the association between infarction and seizures, as well as outcome in seizures, held true for the low-grade aneurysmal subarachnoid hemorrhage group, but not in sub-analysis for just the high-grade group. Is this a difference in the overall expected outcome of high-grade, or do you think there's something else physiologically that's going on in that population?
So there are sort of two things that are going on here. First, the association with outcome and seizures in the high-grade overall, I think those patients just have a worse outcome. You know, we really only see in the 20 to 25% range of these patients having good outcomes overall. So whether or not they have a seizure, I think there's already enough injury and secondary injury that the seizures may be not that important a factor for them. In regards to the lack of difference in the clipping versus coiling group in high-grade patients, I think that really is more due to just the practice of the neurosurgery and endovascular groups at Cornell, where there's an extreme preference towards endovascular treatment in high-grade patients.
I think, 72% of people underwent coiling?
But in the high grades, it's even more so.
Even more so.
In table 1, so Hunt S 4 and 5, only 8 of those patients were clipped versus 55 coiled. So, it's a significantly higher percentage of patients for high grade that are being coiled.
Let's talk a little bit more about that seizures were almost non-occurrent in low-grade subarachnoid hemorrhage patients. And I think the incidence was actually, overall, you had 6.4%, but the vast majority of them occurred in the high-grade group, which was 12.7%, compared to the low-grade group, which was 3.9%. But you found overall that seizures were very rare in aneurysmal subarachnoid hemorrhage patients, which I think, at least to me, was surprising because I think of it as a relatively high burden for these patients.
Again, I think 7% is still a fair number, and we're not necessarily capturing every single patient that's having seizure. The patients who are higher grade at Cornell, they're not kept on EEG for weeks on end. So we could be missing, multiple patients that are having seizures in that high grade group, but we're not seeing them in the first, 2 to 3 days of monitoring. So we could certainly be missing several patients in the higher grades that are like that. And then in the low grade patients, a lot of the data that has higher incidence of seizure is focusing just on patients who are on EEG. So they've already been pre-selected as more likely to have seizure than the total population.
What do you think, in your mind, from a clinical perspective, are the most important takeaway points from this research?
So I think the most important thing to me is the potential for impact on choosing treatment modality in low-grade patients. Low-grade patients who are coiled, again, this is just at our center, had an incredibly low chance of having a seizure and did very, very well overall. Only 2 patients who were coiled had seizures versus 6 of the high-grade patients that were coiled. So clipping had a significant impact on the number of patients who are having seizure. And that actually may be another reason that we're seeing a lower incidence than some of these other studies. If you look at the breakdown of clipping versus coiling in the data that came out of Columbia, the vast majority of those patients were clipped. And if you look at population breakdowns from the various inpatient samples and the ISAT trial, the percentage of patients who had seizure, or really looking at epilepsy, that had seizure after coiling was lower. So I think our cohort, being significantly more likely to be coiled, would have a lower overall incidence of seizure as well.
That certainly makes a lot of sense and is consistent with the literature you review.
I do think that this data could be useful in resource utilization. We talk a lot about what hospitals need in terms of staffing, in terms of workload on various doctors and residents and staff. And having patients on continuous EEG is a relatively time-intensive process. It requires a tech who can fix the EEG leads when something's wrong. It requires somebody to be monitoring it, if you're really going to do this correctly, 24 hours a day. It requires an attending to read it. And, it's costly both in terms of dollar amounts as well as in terms of the time. So when we figure out the patients that should and shouldn't be on it a little bit more discreetly, I think that could be helpful in terms of utilization of a often limited resource.
Absolutely. That's a really good point. Moving to my final question is, if you were offered kind of unlimited funding moving forward to design a trial in whatever way you saw fit, what would be the next step you would take in further elucidating the understanding between seizures and subarachnoid hemorrhage?
It would involve multiple centers. First of all, a high quality or high volume center will see somewhere between 40 and 100 subarachnoid hemorrhages a year. When you have a process that is relatively rare and you want to study it appropriately, you need more numbers. I think if we had 2 to 3 times the number of patients, we may have seen differences play out over both groups in more of the subgroup analyses that we didn't see with this smaller cohort. I think that we need to have more randomized trials in neurocritical care regarding seizures and subarachnoid hemorrhage. There's an ongoing multi-center trial in TBI, looking at the genesis of epilepsy and traumatic brain injury, post-traumatic epilepsy. And I think something similar would be very helpful in subarachnoid hemorrhage. So if I had unlimited funding, I would push for a multi-center trial to better elucidate the causes of seizure and the progenitors of epilepsy and subarachnoid hemorrhage, so we can find those biomarkers, so we can identify potential areas of treatment and hopefully improve patient outcomes in the long run.
That sounds fantastic. I'm sorry I'm not in the position to offer that funding. Well, thank you so much, Dr. Baxter Allen. Dr. Baxter Allen was a neurophysiologist and neurointensivist, and we were just discussing his paper on the association of seizure occurrence with aneurysm treatment modality in aneurysmal subarachnoid hemorrhage patients. This is Sarah Sternmeser. Thank you for listening to the Neurocritical Care podcast.
Thanks for listening to the Neurocritical Care Society podcast. The NCS podcast is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, and education in neurocritical care. Our production staff includes Josh Levine, Mike Brogan, Romani Ballou, Storane Shepard, and Benjamin Miller. Our senior producer is Jim Siegler. Our administrative staff includes Sarah Memon and Becca Stickney. Music by Lee Roussever under Creative Commons license. If you like our show and want to know more about us, check us out on Twitter at Neurocritical, Facebook, or LinkedIn. The NCS podcast is available at NCS On Demand, iTunes, and wherever you may listen to your podcasts. I'm Fawaz Al-Mufti, and thanks for listening.